Hello, everyone. We will begin our discussion on racism as a public health crisis in just a moment. Please bear with us, and we thank you so much for joining us today. Okay. Hello, everyone. Thank you for joining us today for our discussion on racism as a public health crisis. We are so grateful that you're here with us today, and everywhere we turn, governments and municipalities are declaring or considering declarations of calling racism a public health crisis. So here to discuss this important topic with us, we have a wonderful esteemed panel with us today, but I would like to bring you greetings. My name is Maya Watson, and I bring you greetings on behalf of the National Center for Civil and Human Rights and the Health and Human Rights Institute. I would like to welcome each of you here today, and we hope that you are doing well at this time. We want to clarify that the thoughts and ideas expressed today are those of each individual. They do not reflect the views of the National Center for Civil and Human Rights, nor any of its agents, employees, or components. We invite all of our attendees to ask questions through the Q&A link on Zoom, and we will pose those questions to our panelists during the question and answer period at the end of this event. So now we will introduce our panelists. First, we have Professor Jessica Symes. She is an assistant professor of sociology at Boston University, and she's also the associate director of research at the Boston University Center for Antiracist Research and a contributor to the COVID racial data tracker at The Atlantic. Her research contributes to sociological research on racial inequality, mass incarceration, the conditions of prison confinement, and the social structure of cities. Professor Symes received her BA with honors in sociology with a minor in critical theory and social justice from Occidental College and her MA and PhD in sociology from Harvard University. Her research has been supported by the National Science Foundation and the Robert Wood Johnson Foundation. Welcome, Professor Symes. Okay, and now we'll move to our next panelist. We have Commissioner Donna Miller. She is the Cook County Commissioner for the 6th District, and she serves as Vice Chair of Contract Compliance, Workforce Development, and Veterans Committees. She has a background as a healthcare consultant working with leading pharmaceuticals and companies. Donna has tremendous experience in sales, training and development, and bringing together collaborations for new businesses with healthcare companies. She has received numerous awards and recognitions for her professional accomplishments. Commissioner Miller's political involvement includes memberships on the League of Women Voters, serving as board chair for Planned Parenthood of Illinois, second vice president of Illinois Democratic Women, and former president of Democratic Women of the South Suburbs. During the 2016 presidential election, Commissioner Miller was part of the Illinois delegation during the Democratic National Convention, serving on the Rules Committee in Philadelphia, Pennsylvania. She is also a member of Alpha Kappa Alpha sorority. Thank you, Commissioner Miller. Thanks for joining us today. And our final panelist is Dr. Gyrobe Cruz. He is the Medical Director of Transitional Care at Franciscan Health, Olympia Fields, and a member of the Franciscan Alliance Corporate Board. His career started in 1971 at Cook County Hospital, where he spent 10 years learning to be a doctor, but more importantly, learning to respect all human beings as created in the image of God. At County, he learned about compassion. His academic life was initiated at Cook County Hospital's cardiology department, then affiliated with Loyola University, but later with the St. James Hospital relationship with the University of Chicago. He has been part of the medical staff of St. James Hospital and now Franciscan Health for the last 40 years, dividing his time between direct patient care and clinical research. There, he was able to lead the medical quality provided to their patients as president of the medical staff, in conjunction with the Sisters of St. Francis of Perpetual Adoration. Lately, he has become involved with the COVID-19 pandemic as an advocate and morale booster to the overworked and overstressed, but extremely courageous nursing staff. They now know that this group of mostly women have been facing the indescribable life experience of being there for the lonely and critically dying patients who are otherwise totally away from the console of their family and friends. Thank you, Dr. Cruz, for joining us today. It's a pleasure to have all three of our panelists. And so we will begin our discussion on racism as a public health crisis. And Associate Director of Research, Jessica Symes, we'll start with you with our first question. We have heard a lot in the media about the correlation between COVID-19 and race, and how the virus is having a drastically disproportionate impact on Black and Brown communities. What does the data that you've worked on shown about the connection between race and the COVID pandemic?
First, I just want to say thank you so much for having me. It's such an honor to be on this panel and to be able to speak on these issues. I can't think of a more pressing and profound set of questions than the relationship between race and this pandemic, in so many different ways. But I think I'll start us off with some important statistics to kind of bring us into what we know so far. So over 124,000 people have died in the United States in less than 6 months. And this unfathomable loss and collective grief has been felt most in Black, Latinx, and Indigenous communities in the United States. We at the COVID Racial Data Tracker find that Black people comprise 13% of the US population, but over nearly 1/4 of the deaths. And as of today, we estimate 27,000 Black people have died from COVID-19. But these disparities, so I can talk about the disparities at the national as well as at state and local levels, and I'm just going to share some important facts. So we see, first nationally, Black people are dying 2.5 times the rate of white people in the United States. And we believe that estimate is attenuated or smaller because we aren't able to access all of this data because states are not releasing it in a timely and accurate fashion all the time. So that's a huge piece to this. We actually think the disparity is likely larger. And this disparity varies greatly by states. So for example, in Kansas, Black people are dying at nearly 4 times the rate of their overall state population. In Washington, DC, Black people account for 75% of the COVID deaths. We estimate elevated rates of infection among Latinx people in 40 states. In Arizona, we find that Indigenous populations are dying at 5 times the rate of their population. I'm thinking a lot about Georgia right now, and so I thought I would share, what we did is we looked at the counties in the US, all the counties in the US, and we ranked sort of the highest death rates by county. And of the top 5, 4 of those counties are in Georgia and in the whole US, and they're all, their population is majority Black and African American, all of those counties.
Wow.
So for me, as a social scientist, as a researcher who's completely dedicated to making these facts meaningful for the public and for policy, these statistics, this sort of crushing weight of these statistics reveal a deep and profound fact that the pandemic is fundamentally a racist, falling from racist policy. It is fundamentally about systemic racism. It has absolutely nothing to do with individual or cultural propensities, or it has everything to do with choices, policy choices specifically. They are in fact choices, and we could make different choices. I'm happy to keep talking about what I think that means, and what are some of the important structural and systemic factors that might be driving these statistics. And I just want to say too, as a final point, these numbers are chilling. They keep me up at night. They're shocking, but they are no substitute for the real loss and stories. And what those numbers reveal to me is that there's a large amount of community suffering. And so there's a very real human being behind each and every one of those numbers, and their families and communities that surround it.
Thank you so much for those comments, Professor Symes. Those numbers you just read off are heart-wrenching, but you're right. There's a human aspect to all of the numbers that we hear across our news feeds, and so we must remember that as well. Dr. Cruz, let's move to you. Dr. Symes just talked about some of the disparity numbers and the evidence of disparities that are going on in communities across this country. Can you talk about some of the social determinants of health and how they have revealed themselves over the past 5 months during this pandemic?
Absolutely. You know, as a segue from what you just said now, and by the way, I thank Ms. Donna Miller, Ms. Namoti as well, to invite me for this fantastic opportunity to give some advice and some talk about the important things in our lives. But anyway, going back to what we said is that interesting part about the condition we are dealing with now with COVID-19, it affects most of the time in mortality and morbidity of patients who have diseases like hypertension, diabetes, obesity, renal failure, and heart disease, which are preventable disease, by the way. And so it affects the Black population to a much higher degree than the white population. For that reason, mortality is higher. So we know why. And the question is, what do we do with that? The question is, how do we prevent diseases? I propose that we have universal coverage for everyone in this country for preventive disease, everyone. That's a huge step. It looks small, but it's one that's going to prevent that disease from killing people for another condition, including COVID-19. So by doing that, we have a major effect on our population to prevent them from getting into trouble. But we need to know more about that. We need to know that social determinant of health, by the way, it affects 70% what happens to the patient, 70%. In other words, I do 30% in my office, and the rest is social determinant of health. All this condition that can occur. For instance, patient may not be able to show up in the office for many reasons. We did a data evaluation for that about last year and found out that from January 1st of 2019 to March 30, 2019, 27 people failed to come to our office. They failed to come for heart failure follow-up. We found out that from the 27 patients, 9 were dead in September.
Wow.
25% mortality. Why they didn't show up? There are many reasons why not. I have a list of the social determinant of health, about 30 points that we go through every day here. In fact, we see every one patient with heart failure in the hospital. You check for that particular problem. And we see more than not, patients failing to follow your advice because of lack of trust. In other words, we see that most of us, not every physician, I look at the computer, but I look at the patient, and they don't pay attention to what you talk about. So there are ways to solve that problem. I'll talk to you about later as we go along with that.
Thank you, Dr. Cruz. Commissioner Miller, thank you for joining us today as well. Can you talk a little bit about what declaring racism as a public health crisis means? Does it essentially mean that being Black or Latinx or an indigenous person is bad for your health in this country?
Well, thank you. And I just want to thank the National Center for Civil and Human Rights for putting this wonderful forum together with these esteemed panelists. And thank you for all the work you do to raise awareness on these issues. It's so crucially important. But I do want to say that in Cook County, and by the way, Cook County is the second largest county in the country. And so it was interesting to hear Professor Symes count those top four counties in Georgia as having the highest disproportionate deaths. This is where counties do have the ability to have some kind of impact on public health. So our county, actually, we're almost at our year anniversary for a resolution that we put forth last year in July to declare racism, recognizing racism as a public health crisis and declaring racial inequities a public health crisis in Cook County. So we could extend this resolution across the entire country. This definitely needs to be extended in those 4 counties mentioned in Georgia. And if other counties adopted this, it does go to your point, Maya, that is being Black, Latinx, or Indigenous a public health crisis for those groups? And it absolutely is. For the major reasons that Dr. Cruz also identified, that in each category, no matter whether we're in a pandemic, having COVID, or just the disproportionate inequities we have in the top 3 disease states, whether they be heart disease, diabetes, asthma, obesity, we could go down the list, but those are the top factors that consistently have high rates of death due to each one of those categories in a pandemic or not. So the issue is that we need to declare racism as a public health crisis because it disproportionately affects all of those different communities, and it's not new. It's been disproportionately affecting every community. Dr. Cruz knows the data, at least for the last 30 years. Heart disease is the #1 killer of African Americans across the country, and it didn't just start this year, it's been for the last 30 years. So how do we go in and change the social determinants of health to impact and decrease, not even just decrease, we really need to stop that progression of disease states in those different areas. I do just want to read one statistic that is important for Cook County, is that in 2018, the diabetes diagnosis in African Americans was 1.9% higher than non-minorities, and Latino, Latinx community diagnosis was 1.7% higher. So already that disproportionate rate causes the diagnosis of diabetes, but then when we get to the deaths due to diabetes, it's #1. Wow. So that's across the board in each one of those categories, whether it's heart disease, diabetes, obesity, and asthma. And so we as a county board, because we have a county hospital system, we want to make sure that we are impacting those disease states everywhere along the line. And I also want to mention that racism as a public health crisis was also declared by 39 different hospitals across the state of Illinois. So that helps raise the awareness from the professionals, for the healthcare professionals, from those who are in the community activists, as well as people just having an elevated sense of what that means.
That's important to have the medical professionals and the hospital systems and the local governments working together at this time to work on the issues of racism being a public health crisis. So thank you for sharing that information, Commissioner Miller. Professor Symes, let's move to you. We know that we are on the heels of and still experiencing widespread demonstrations that have come from killings of unarmed Black men and Black women at the hands of law enforcement of this country. And like Commissioner Miller said, just like obesity and diabetes and heart disease, those things not being new in our communities, and they've been around for decades. Police brutality in Black and brown communities is also not new. Can you talk a little bit about the connection between the COVID pandemic and policing and communities across this country?
Absolutely. I think the pandemic and policing in America are deeply connected, and they're rooted in this unresolved crisis of racial inequality in the United States. Just some background on policing and what we know, aggressive policing practices, and even just everyday interactions like stop and frisks, Terry stops, broken windows policing has had a tremendous negative impact on communities of color, and especially Black communities. The police made over 10 million arrests last year alone. And that's arrests. And so the level and the degree to which the police are in people's lives is something that communities of color have been talking about for for a very long time. And I think what we're seeing, why this is connected to the pandemic and why it's so important that this is happening now, is we're hearing stories from Black and Indigenous and Latinx communities, as well as activists and news reports, that 911 calls and policing are the primary tools in which cities are enforcing social distancing guidelines. And so one possible consequence of we're sort of grappling with the reality that the United States has decided to deputize police officers to be the #1 response to public health crises. And what that means is communities of color are going to be exposed to enhanced police contact during a time when they need support, they need health responses. And so some of my research is trying to investigate, is the pandemic actually increasing the police contact for these low-level types of interactions and exposing, while more affluent communities are actually accessing healthcare resources? So we're in this moment where the United States is grappling with police using violence to suppress protesters, which violates the basic pillars of a democratic society. And when we talk about defunding police, we're talking not just taking police out of communities, but having the same kinds of community investments that affluent white communities have, that are protective against COVID, the spread of COVID, but also protective against police interaction, unnecessary police interaction that has caused so much exposure to violence from police officers. So that's how I see these things connected. I think that we have to think very deeply about what it means to have police be kind of the first response during a major health crisis.
Thank you, Professor Symes, and I think that's so important. And I don't know if your data has bared this out, but I've heard that Blacks, even though we're 13% of the population, we're killed at 3 times the rate of whites from police encounters as well across this country. And so having police as the first responders in the pandemic is also telling in that respect as well, wouldn't you say?
Absolutely. And something I say in this work that I'm doing is Black communities in particular are facing this pandemic from all sides. You know, there's these disproportionate rates of COVID infection and death. There's also disproportionate interactions with police. There's also going to be, you know, disproportionate economic precarity due to unemployment. So it's profoundly about this larger system of racism that is driving all of these disadvantages, and we can make different choices. It seems so intractable, but we can actually make changes that will make people's lives healthier and less affected by the harms of interactions with the police and the state.
Thank you. Dr. Cruz, let's go back to our discussion about the social determinants of health. Is institutional racism, can we add that to the list of the social determinants of health?
Yes, you can. As I said before, trust is very important. And it's very difficult to adapt the same talking that we do to a person to make sure they listen to what you're saying. Let me give an example of that. I had a patient about a year ago. He came to see me for the first time. And the reason why he came to me is because he had come into the hospital every 2 weeks. He was in the hospital every 2 weeks. Admission. I finally came with his wife and I asked him, why you do that? I'll take my medications, and well, you may or may not believe it. And then I finally it down to me to ask one crucial question. Do you trust your physicians? He looked at me, his wife looked at him, he said, hell no. So we realized then that we need to be there with them rather than waiting for them to come to us. So we said, okay, let's do something new here. Let's go to the community because that's where they are. I mean, why would we stay here in our little building and wait for people to come to us? Let's go there and have people to help us to do that as well. So we have plans to solve some problems. As I said before, we intend to have a health community coach for health within the community. We train them in our hospital. We make sure they work with us together. and go to the community. That's a massive step to be there at the time when they need to. So that would be one way to solve those problems, because people that come to us when they're very sick, you know what they do? They go home. We tell them, you need home health care to take care of your problems. We tell you what medication to take, what drugs to follow, what diet, and you know what? They refuse. 1/3 of people, very sick people, don't want anybody in their homes. So I asked the question, why not? Safety, number one. Number two, they don't want people inside the house. I said, okay, so why don't we do the following? Let's get a van, put everything we can have to treat the patient, bring the office to their home. The ones that cannot walk, the ones that are very high risk, and the homeless. Believe it or not, treating homeless saves money because they will come to the hospital anyway, no matter what. So there are ways to solve those problems, particularly when people are resistant to have medical care because of trust, which is a major social problem. And we have to solve the problem as well.
Thank you so much, Dr. Cruz. Commissioner Miller, racism has, for, you know, at the introduction of the first African on the soil of America, has been a public health crisis. Why are local governments and states only now declaring it as a public health crisis?
You know, that question really gets amplified by who has a seat at the table. And I think that part of the conversation being elevated comes from the fact that there's more diversity in our political system. Think of all the women who were recently elected to Congress in the last electoral session. Even on our commission, on our board, there's 17 commissioners. Well, we finally, as of when I was elected into office, there were only 2 women. Now there's 5 women out of 17. Not great, but better. And 3 women of color out of that 5. So I think that elevating the conversation comes from people being in the communities that it's affecting and asking the questions, what can we do better? And then having people, the people who might not be part of that community are also invited into the conversation by those of us who know the community. That's why I love what Dr. Cruz said just too about having the public health or having the healthcare system go out into the community to talk to patients where they are, meet people where they are. And it's not a hard concept, but it's a concept that is not universal. So it would be great to see that happen. The other thing is when we look at how government and legislatures and hospital systems and hospital boards are also incorporating racism in. I mentioned the 36 different hospitals in the state of Illinois or organizations. So they've also identified steps that they want to use as a universal guide for all 36 to have consistency on eradicating systemic racism. So that conversation didn't happen overnight. And to get that number as the initial inaugural number of organizations and hospitals that are going to take on this fight will also infiltrate the other hospital systems that may not think it's necessary for them, or that doesn't happen in their community, so they don't need these steps. But talking about the steps, that's what raises the conversation and takes it to another level. I'm excited to see that happen. And I did mention Cook County Health and Hospital System as being one of the hospitals. And that is very important because of the patients that the county serves. The county is open to all, regardless of ability to pay. Now, that's good and bad, because we do have highly qualified physicians and nurses and staff there to take care of patients no matter what their ailment. But then also the hospital system is being broken by the other for-profit hospital systems that do not take on indigent care. And we have the most patients who have the inability to pay come through our system. We need to have that ability through the for other for-profit hospitals to take on that burden as well and not send all the patients to the county to be served. So Franciscan Health, where Dr. Cruz works, they do take on that role as part of being in the community that they serve. And we need other hospital systems, which could be another part of our conversation when we talk about systemic racism, because if you're not fortunate enough to be here in Cook County and be able to take part in a county system, a county hospital system, where do you go? So if patients who have the ability to get care are not getting care because of trust or because of whatever other reason, not making an appointment, what do we think is happening to all the other patients? And then there's where we have that disproportionate number of the inequities in Black and Brown communities and failure to be able to serve those people when they're in need.
Thank you so much, Commissioner. And since you noted that Cook County is the second largest county in the country, what are the driving factors for Cook County in declaring racism as a public health crisis? Because I'm sure it differs across municipality and jurisdiction. So for Cook County, what are the driving factors for that declaration?
Well, it does differ across municipalities. However, Cook County represents the city of Chicago and 130 other municipalities. So 50% of Cook County is the city of Chicago. So that's the big number. But then 50% is not. The smaller municipalities that reside outside of outside of the city of Chicago, we refer to all of that as suburban Cook. The numbers are disproportionately the same whether you're in the city of Chicago or outside of the city of Chicago. So I think that allows Cook County to kind of be a model to tell the story of inequities in healthcare in high African American, Latinx, Indigenous. I don't know if we track those as well as we should, but I know that that's coming. But Cook County has the ability to extrapolate numbers based off of those top disease states in every part of Cook County. So I think that how that gets highlighted is just when we see what's happened with this pandemic. The first death, unfortunately, in Illinois was in Cook County. And the first woman and it was an African-American woman, she had diabetes, and unfortunately, she was our first fatality, but she had all the risk factors. And then the other unfortunate part of that story was before people realized about social distancing and wearing the mask, and it was too late because other members of her family contracted COVID-19, and then her sister also passed away of coronavirus. So that impact on one family in a small area, this was in the city of Chicago, has far-reaching effects to everyone who was associated with them. And that's how we can learn from that situation, but also we can say, how can we impact that? Because again, that disproportionate, having diabetes, being predisposed already, and then having COVID on top of it, this is where we need to impact the hospital system and hospital care at an earlier point.
Absolutely. Thank you, Commissioner. We do want to encourage our audience, if you have questions for our esteemed panel, please put those questions in the Q&A link option on Zoom. And right now we have a few questions that I'd like to pose to our panel. Our first attendee asks, now that we've accepted the fact that racism is a public health crisis, what are the long-term plans to reverse this dilemma? And will there be an economic factor for marginalized community members within your plan? So any of our panelists can answer that question. So what are the long-term plans to reverse this? Sorry, go ahead, Professor.
I can speak from the perspective of the Boston University Center for Antiracist Research. Our goal is largely to build the nation's largest data tracker on racism in America. And we believe that that information has to be responsive to the public's needs. So we want to engage with communities and find out what are some of the most pressing issues. I can speak broadly in my perspective on sort of what's next and why I believe personally that abolition and reparations are profound are really important next steps. And I think when people hear those terms, they immediately conjure a society where there's no police and there's nothing else in its place, and the simple transfer of wealth from white people to Black people. But these are really extremely narrow visions of what I believe justice would be in society. So I absolutely see there being an economic factor. I mean, speaking of Cook County, one great example of this is Evanston, Illinois, who took a very hard look at the history of redlining in their city, and they voted to use 100% of taxes on cannabis sales to create a system of reparations in their community. So when I was saying earlier, these things seem so intractable, so historically embedded, so enduring. And yet, I think communities actually, specifically in the case of public health and policing, have actually a lot of efficacy here because our police are run by local institutions, and we can see these policy changes happening on the ground. And so a huge part of this is actually drawing on the existing work of current community activists and organizers who are building and envisioning justice for their communities currently. And we hope as a center to provide sort of a historical, longitudinal, as well as kind of contextual set of data for communities to draw on to answer some of these policy questions.
Thank you, Professor. I think we can have a whole webinar about reparations, and
absolutely.
I
would love to hear that
discussion. Okay, the CEO and president of the National Center for Civil and Human Rights, Jill Savage, she asks, how can citizens get involved in campaigns to call racism a public health crisis? And Commissioner Miller, if you'd like to start the discussion with that, then that would be great.
Yeah, I think that there is a great opportunity for all the activists to unite, okay, around a central theme. So we could just take the example, and I keep referring back to this example because I think that it's really probably groundbreaking that 36 institutions here have taken on this cause and have a 7-point agenda. The other thing is that they represent 8 million patients, 8 million patient lives. So if we could take that model and replicate it across the country for, let's say, the top 10 counties in the country, make sure that they have a resolution that identifies racism as a public health issue. And then we can have our activists help support that mission by being vocal advocates for it, by coming to the board meetings where it's not in effect and saying that it should be in effect, coming to local municipalities that may have a large hospital system in their community. And if that hospital system does not identify racism, having that conversation so that we go to the board of the hospital, we go to the municipality and say, this is what needs to happen because you're serving the community here, but you haven't identified this as an issue. And this is the only way we're going to get this to turn around. So I think there's a lot of things that community can do, activists can do, form groups. I always say that before I got into public office, I was an advocate on every level. I believe in the power of writing letters and advocacy. I believe in the power of showing up to board meetings. And it only takes one person to start the idea. And then it takes other people to say, yeah, I agree with that idea and I'll follow you and I'll join you and I'll tell my friends. And then that's how ideas get spread. So I often talk of the power of one. There is the power of one person. So if this one person who posed that question would like to start that ripple effect, it starts with investigation. So I'd say the first thing to do is find out if your county has identified racism as a public health issue and what the hospitals, if there's a public health hospital in your area, what the hospital is doing about it.
Thank you, Commissioner. While we still have you, someone asks, is there model legislation that Cook County has or that you all worked from that could help other municipalities and state governments declare racism as a public health crisis?
Well, yeah, and so just with any sort of legislation, you don't have to reinvent the wheel. This legislation is already published It's already out there. And we'd be happy if anyone wanted to contact my office. We have policy people in every capacity, whether it's just out of my office, whether it's out of the broader hospital system. So we'd be happy to share the legislation and provide ideas based off of your county, but it's really that easy. And also this information was taken to our, so there's an organization called NACO, National Association of Counties. And our chair from the hospital system from the county board is Commissioner Dennis Deere, and he's going to present this at NACO for just that reason, so that other counties don't have to think, how do I do this? What should I do? Just take this model, replicate it, retrofit it to your county, and then we can have consistency. At least my goal would be to see the top 10 counties in the country at least adopt that because of the millions of people they represent.
Thank you, Commissioner. Dr. Cruz, let's turn to you. Professor Symes mentioned that the #1 killer of Blacks before the pandemic was cardiovascular disease, I believe. And we know that African Americans die disproportionately from cardiovascular disease than any other group. And perhaps it's the fact that 1 in 3 African Americans live in a food desert in this country compared to 1 in 12 whites. One of our attendees, Rick Doolin, has asked, how is placement of fast food establishments related to health outcomes and racism? And are there any strategic plans to address these issues? So how is the placement of fast food restaurants and places in Black and brown communities, how is that related to health outcomes?
It's huge effect. Imagine that you're a 75-year-old and you live by yourself, and you cannot go across the street or across the block to find a place where they can buy the right food, vegetables, things that can keep them healthy. They got to take a bus, and the bus goes all the way somewhere across the street, across the city to find a place where they can buy those things. The difficulties provide them no opportunity at all to find the right stuff. So what do? They select themselves to the food that produce more diseases, more hypertension, more diabetes, more obesity, which should not happen. We have a problem of having food at the right place. It's what they call food, this desert. And some areas in Chicago, some areas even here, we see that happening right now. Now, I really go back to what I've said before. I think that we have to put people together. There's a old African proverb that says, if you're gonna go fast, you go alone. If you're gonna go far, you go together. Mm-hmm. Well, now we have to go far and fast because we're late already. How do you do those things? Well, I thought about doing something very interesting. Create a forum where we put everybody together in one place. I call Forum of Social Determinant of Health. And we supposed to have that on May 8, May 9, right in the middle of the pandemic. So we had to postpone that. But the idea was to have community leaders all the way from the city, county, state, federal, in industries, in the local industries, local shops, and everybody, churches, community centers, city blocks, individual families, and home. And our brothers and sisters should get together to make sure we all work in the same place. We can't go too fast when you do that, but at least can plan to go far. If we don't do that, association of people to work together, nothing's gonna happen. Ms. Donna Miller can work on her side, but she will need a lot of people behind her, like I can't do that. We make sure that we push her and we can achieve the results that we're gonna do. We're gonna change the way we do things by providing this community of people working together in one place.
Thank you, Dr. Cruz. And you mentioned that there was a forum on the social determinants of health that was originally scheduled for May. Has that been postponed?
Yes, it is. We kind of, COVID-19 hit our hospital very heavily. We had about 80% of our patients had COVID-19 in our hospital, which is, imagine what it can do to a facility like that. So we slowed down the process of everything we're doing at that time. Now, because we don't know the end of COVID-19, nobody knows that yet, we have to say, maybe you should do the forum in a different way. Let's do a webinar where we put everyone that I just told you now together, including you, by the way, to make sure we talk about solutions. No talking about problems. Let's talk about solutions. Let's see how we solve those things that were just dear to us and make sure we move in the right direction. We should be done, and we'll be done happening before the end of the year.
Thank you so much, Dr. Cruz. Professor Symes, Sawyer Stewart asks that you repeat the 4 counties in Georgia with the largest number of African Americans infected by COVID-19.
Absolutely. So I mentioned, just to reiterate the whole statistic, so we looked at the counties in the US and looked at the rates of COVID deaths among all people within that county. And we ranked sort of based on those rates. And I want to also encourage everybody to go to COVID tracking, our website and Twitter, where we release this information all the time. I can share a link in the chat when I'm done. So we looked at all the counties with the highest death rates overall, and 4 of them are in Georgia, and they're all rural counties, small counties. So Hancock, Randolph, I'm not from Georgia, I think it's Terrell, and Early. Those are the 4 counties, so all with populations less than 15,000. The extreme sort of other end of the distribution from Cook County. And so a big part of that message, right, is that it's not just the big cities. We focused a lot on that because of density and the way that we think this is transmitted, but it's also the rural and smaller counties that are really impacted by this. And so each of those 4 counties, the majority of their population, according to the US Census, is Black or African American.
Thank you, Professor. Commissioner Miller, an attendee asks, what role do you think the federal government plays in not only declaring racism as a public health crisis, but also addressing it?
Well, the federal government first does need to identify that. And I do believe there was legislation by Senator Kamala Harris and Senator Booker to make sure that they were putting out the numbers of deaths and the numbers in each category for health disparities for African Americans and the Latinx community. It's amazing to think that those numbers were not readily available. And so that's a role the federal government can play, to insist that in every report and in every data set that we get, that we identify those numbers. Now that doesn't just have to stop at the federal level. We can trickle that down into every level of government, whether it be county, state, or municipality. And I think the other thing that needs to happen once that does happen, or even if it doesn't happen, I think we do a really good job here in Cook County of identifying those numbers. But unless you're looking for those numbers, you're not going to see them. So we need to get those into the hands of people who need to see them. And this all goes back to communication, meeting people where they are, healthcare literacy conversations. If I say, oh, go to the data port and look up the incidence of diabetes, if I say that to a person who's like, I don't know what that means, they're not going to go look that up. But if I hand you the numbers and say, here are the different zip codes, here is how diabetes affects every zip code, and you live in this zip code or in this town, here is what's going on in your town, then that is something that someone can use. Same thing that happened when we started promoting the numbers on a municipal level for COVID-19. At first, we just saw all of Illinois, then we saw city of Chicago, so people in the suburbs didn't even think, oh, we're like, well, we're safe, we don't have COVID out here. And then when we started showing those numbers, people started getting a little more intentional and serious about what they were doing. So numbers tell a great story. I'm sure Professor Symes can identify with that as well, but we have to make sure that we get the data in a usable format for regular people, and where people can access it easily.
So how would the declaration look in a federal, on the federal landscape, how would that be different? Declaring racism as a public health crisis in Cook County, I'm sure it looks one way. How would that look different on the broader scale?
Well, on the broader scale, if they legislated things, they could take different pieces of it and make it laws around different things. A resolution on our level is just heightened awareness, but then it also, on a county level, it helps us, guide different conversations on everything from procurement to healthcare to environment. So it helps us guide those conversations. But on a federal level, I think they can have laws in place. They can have things that impact all the way down to the state level. So that's where we need to dig in and see what that means and how they can make legislation that does apply to racism, that's in bite-sized enough pieces that it's actually meaningful.
Thank you, Commissioner. Professor Symes, Jeanette Konecki asks, what are the health protections that affluent communities have that others don't? So I think this question is alluding back to our discussion about the disparities, the health disparities that occur in this country.
Yeah, and I would encourage my fellow panelists to jump in too, because I'm sure they've spent a lifetime thinking about the placement of healthcare resources. I mean, there are so many ways to respond to this, but I can share sort of a vignette. I'm a geographer, and I use mapping as a way to tell these data stories. And when you do a map of Boston, which is where I'm hailing from, you can see that there is almost a complete negative space of healthcare resources in the Black community. So Black residents of Boston have to drive so much further to get to an emergency hospital. There also, our transit system outlines the Black community, like it just goes around it. And so having regular access to transportation and healthcare, this is something that affluent communities have amassed the most resources in terms of community-based as well as emergency healthcare. And I wouldn't just stop there. It's not just our healthcare institutions, it's also access to healthcare through insurance. Medicaid expansion under the Affordable Care Act brought millions of people into care that were not receiving care. And we could imagine, as there are many proposals on the table, for ways that we could go even further. So Medicaid expansion under the Affordable Care Act only went up to 138% of the poverty line, which many people, who live in actual poverty know that's still poverty. But also we could imagine people losing their employer-based insurance in the coming months, or have already. We're facing an unemployment crisis of historic proportions. So a lot of our choices and our policy choices and our investments have shown that they cannot withstand a pandemic. And we have to think of broad, systemic, and sort of square one, kind of solutions, because to not be able to access care during a pandemic is what is leading to completely preventable death in communities of color, and huge gains that occurred due to the ACA were in the Black community specifically, and also because of Supreme Court decisions, states have the option of opting out of Medicaid expansion. So many states where there are large Black populations, where there was no expansion of Medicaid. We have to create real systemic solutions to access to healthcare. I think that some of our political candidates are talking about that.
Thank you, Professor Symes. Dr. Cruz, can you talk about the impact that mobile hospitals can bring to communities?
Can you imagine if I can bring a van with a nurse, with a paramedics, with all the laboratory results back there, the bed to be examined, EKG testing, and I sit down in your community and say, look, we're here for you. We're here to provide you the best care, even though you can't come to me. We are in the community, we'll be part of it, which is crucial for it to do. So we can provide that care that's needed for the most needed people and vulnerable people as well. As I mentioned before, even the homeless should be taken care, not just, by the way, homeless is a problem in Chicago because in the summertime, we can find a place for them. And sometimes they have no place to go except be in the street. So we can find the people to take care and not only prevent them from getting sicker and dying, but also prevent from the money that we have to spend with them when they come to the hospital. Let me give you an idea. Metro South was a hospital that was in Blue Island, just at the border with Chicago. It had to close. Once they closed, all the patients from that area migrated south to Ingalls Hospital, which is south of Blue Island. When Ingalls Hospital got full, they migrated to South Suburban Hospital, which got full as well. And they migrated then to St. James, Olympia Fields Hospital, which then we got a full. So, there was rebound back when they closed the hospital. About 6 months ago, about 4 hospitals in Chicago and Commissioner Miller might know about that, Trinity and others, 3 more of those, they attempted to get together because they can't handle anymore the money they have to put together to pay for the care. And what happened to those people, those hospitals, that they had less money than the other rich hospitals. The NFL does the other way around. If you see how the draft is made up, if the lower ranking team gets the first draft, the hospitals the other way around. The poorer hospital gets less money. Once they get less money, they close. Once you close, it'll be the same thing as not having a food desert. We have a hospital desert. You have to travel, like she just said now, long distance to get care, and we're going to bring to them rather than wait for them to come over to us.
Wow. Thank you, Dr. Cruz. We want to take this time to thank our very illustrious panelists who have been with us, who have volunteered their love, their commitment, their expression, their research, and their care for our community. We thank you for your time, Dr. Jairo Cruz, Professor Jessica Symes, Commissioner Donna Miller. Thank you so much for joining us today as we talk about this very important topic of racism being a public health crisis. Of course, with limited time, we can only touch on some of the issues that come from this topic. And so there's much more to explore. There will be a recording of this video. If anyone would like to go back and visit that, please visit the National Center for Civil and Human Rights website or their YouTube page where it will be uploaded. So thank you all for attending. Thank you to our panelists as well. We definitely want to invite you all to come back for our upcoming programs. We have a program called Justice for All, Freedom of the Press, where we will be launching a new series on July 17th that will be centered around the amendments to the US Constitution. Each program will focus on one amendment and feature a dialogue that explores its historical and modern significance. So we invite you to that program. Another program is Equitable Diners, Lift Every Voice. That will launch on July 19th. It will be a short play and include guest speakers and a discussion about how race, equity, and education can occur during the pandemic. And finally, we have Civics 101, Why Should I Care About and Complete the Census? On July 24th, we will have a virtual happy hour where we will break down all of the reasons why the census and completing the census is so important. So we want to invite our attendees back to view those programs as well. And we thank you so much for joining us today. We hope that you got something from this broadcast, and we want to thank Donna Miller, Jessica Symes, and Jairo Cruz. Do any of you have any final remarks before we end this broadcast on racism being a public health crisis? Dr. Cruz, we can start with you.
Yes, as I said before, we have to go fast and far. We gotta get together. If we don't put our heads together, we go nowhere. We can't fight each other. We have to put the team, a family together here.
Thank you so much, Dr. Cruz. Professor Symes, how about you?
Yeah, I just want to say, I want to invite people to check out the BU Center for Antiracist Research. There's ways to get involved as individuals. And then also the COVID racial data tracker, please go check it out. I included a link in the chat. There's also ways to volunteer with the tracker itself. So please, please contact us if you're interested in getting more involved. Thank you.
Thank you, Professor. And Commissioner Donna Miller, you will round us out.
Well, thank you. This was excellent. And I just want to say to all those who are listening, if you don't know what to do, come check out a county board meeting. They're open to the public, and right now they're probably virtually being done. So I would just say get engaged, help be vocal advocates, go to your local municipal meetings, go to a school board meeting, go check out your state legislature, because that's how you find out what's going on, and you might just be shocked by what you hear.
Very important message. Thank you all. We appreciate you all for joining us. We hope you have a wonderful day today, and we hope that you all stay well. And we thank you from the National Center for Civil and Human Rights. Have a great day.